Uh, Thank you. To help us describe green social prescribing in the UK. So, for those of you that are our colleagues in the Nature and Health Alliance, we have an alliance, a network called the Academic and Researchers. The Academic and Practitioners Research in Nature Network. We call it APRIN for short because it doesn't exactly roll off the tongue. And that group is a real healthy mix of academics and practitioners, a bit top heavy with academics, about 60%, who meet regularly to explore some of the challenges around how we get the evidence for nature-based interventions, what we do, how we work collaboratively. Myself and Taylor met last year. We were really interested in the concept of virtual reality, so virtual nature. And so an amazing group of people from the Nature and Health Alliance came to talk to the APRIN Network last year about their virtual nature. And we were all just absolutely blown away with the quality of the work, what they were doing, the impact it was having on people's lives. And so we set up this symposium to kind of share what we're doing in the UK. And once we'd done that, we realised what we're doing is quite complex. And there's a lot of misunderstanding and a lot of myth busting and a lot of kind of context around the use of nature for well-being. So we thought it might be worth just having a symposium just to kind of explore that and do some Q&A and get some really great speakers in to discuss that. And then have a second symposia where we can provide some really great examples of how that's being delivered in the UK, and some of the challenges and some of the solutions. So that's the cunning plan. We're hoping that tech doesn't fail us. We're hoping that people can share their slides. It's really informal. We're hoping that this generates some really good discussion. And we're hoping that we'll be able to share this afterwards as well. So what I'm going to do now is shut up because I do tend to waffle. And if I can invite you just to put who you are in the chat box so we know who's in the room, that'd be brilliant. And then I will hand over to our first speaker, which is Dr. Rachel Bragg, OBE. And Rachel has been working in the sector for a number of years and has been awarded a national accolade for her work and expertise in this area. And she won't tell you that, but we will. We'll absolutely tell you what an expert Rachel is. So I'm going to introduce Rachel, who's going to talk us through the kind of 3 pillars of nature engagement. And then after that, we're going to invite Dr. Jessica Thompson, who's the director of City of Trees, who completed a PhD around this area, which will take us around the pathways and understanding the systems that support people to access the various pillars in nature. And then we'll come to Dr. Harriet Hunt, who was one of the leads for the national evaluation of the Test and Learn Green Social Prescribing provision, who's going to give us some insights into what they learned about that. And then we'll do a Q&A. Right, take a breath, enjoy the session, and Rachel, over to you.
Right. Hello. Have I managed? I'm a bit of not very good with Zoom. I'm better with Teams. Have I managed to share the presentation first of all?
Yeah.
Great.
Yeah.
That's the first hurdle. So yes, first of all, hi, hello. It's lovely to be here this afternoon. As Michelle says, I've been lucky enough to have been working in this sector under many guises for the last, Michelle was very kind, 20 plus years I've put here to just to make it vague. And delighted to see how the nature, health and wellbeing sector in the UK has grown so much over that time. Even so, as Michelle said, we've got some way to go in terms of reliable referral pathways, sustainable funding for provision and for consistent definitions and terminology, but we really are getting there. And I'm going to share some of that journey in terms of definitions and terminology with you as a bit of a background context so you can see where we are. So this is the first technical thing. Has that advanced? No, there we go. Right. So we've got a real choice of nature-based opportunities in the UK. Many organisations are delivering something green, and we found particularly after the pandemic Many people, many more people now get the connection between nature, health, and our well-being. And our sector includes all sorts of different activities for different service user, client, participants groups with a range of different focus, whether that's health or social care, rehabilitation, all sorts of things. And participants are referred in from many different routes, whether that's social care, special education, and health. Jess is going to be talking more about that in a bit, so I'm going to and not say any more about referrals. And things like social care and education quite well established in using nature-based interventions or activities, and health is now starting to catch up, I'm pleased to say. So, oh, we got. There we go. What's in a term? So, as I said, the enormous array of different terms that we use to describe what we do is unfortunately or has added to the confusion from people looking in from the outside. And we've been discussing a sort of consistent terminology and definitions really since, well, for 20 years, since 2006. And these discussions have really gathered a pace now that the sector is much more established. So we've got many terms used to describe the services being provided, both in the UK and internationally, different definitions, different understandings, and obviously different personal preference. We all like to use different terms and terms that maybe suit our organisation. And in the UK, we really recognise the need to agree some consistent language to reduce confusion. And so we're not asking practitioners to rename or to change what they deliver, but rather to see what they do fits into the wider sector. So this is where it started. I'm going to show you a variety of different visuals just to show you kind of how the sector has moved along in the last 20 years. This is where, well, for me, where it started in 2006. This is the Green Exercise Research Team at the University of Essex, and also with EU research collaborations. And we identified 3 different pillars of engagement with nature. And we then identified different activities that fell within these pillars. And at that time, we looked at whether they were passive or interactive. So that's one way, and you can see all sorts of different things in the pillars there. I'm going to sort of whiz through these because we really have we've moved on in terms of how we talk about things, and so that's sort of where it started. Then one of the columns, what we called green care, which is the sort of nature-based therapy end, it sort of morphed into my green care umbrella, which basically was to show both the variety in nature-based interventions, whether you're using animals, gardening, farming, all sorts of things, wilderness, ecotherapy, whatever it is that you're doing. And we wanted to show the variety in the different interventions out there. And this diagram has been widely used over the years to show that there are lots of variety, there's much variety in context, but they all come under one broad heading. And of course, if I was doing this again now, I'd be adding things like forest bathing, surf therapy, and all sorts of new interventions, new to us interventions into that as well. So as the years went by, we modified our umbrella and our pillars into circles, and we modified this to fit changing contexts. So this is our 3 circles approach. Originally, the little green care bubble was at the bottom, but we moved it round because the NHS model in the UK showed a pyramid, and we wanted to sort of align our services to a nice pyramid. So we upturned our model. And this model has been in circulation in one form or another for at least a decade. We originally developed this one to communicate with the health sector using sort of health-based language in order to explain the differences between the levels of nature-based provision and between some of the delivery terms, just to help navigate our way through the confusion. It's been really successful and widely used. It's dynamic and it's been tweaked over the years, but the focus on this one is really on the type of provision rather than the needs of the individual. And as you can, I'm not going to read everything out in the model, but oh, I've discovered a new way of clicking forward in Zoom. So yeah, so this is what I wanted to move on to is that so we've seen much change, but the three types of provision have really endured. Even though we haven't had agreement necessarily on what we call them, we've generally the fact that there are three different broad types, if you like, has endured, and there's been wide agreement that these exist, but no agreement of exact terminology. But we're increasingly seeing a bit of a trend to adopt these definitions. So although these were based on our originals, these tweaked versions are being used in the EU-wide Horizon-funded Green Me project, which is EU, but also includes the UK and the US. So in this, we've sort of adopted more specific names, if you like, for the pillars, and green care here refers to the whole shebang. So yeah, so we've got nature in everyday life, engagement with nature as people's normal lifestyles. Then we've got nature-based health promotion, and these are organised activities to engage people with nature, and right through to the nature-based therapy, which is nature-based therapeutic interventions. So similar, but a little bit more specific. And I suspect that because it's more specific, this is why it's the uptake. So the next thing I wanted to show you is a piece of work that came out of the Green Social Prescribing pilot here in the UK, and it shifted the focus of looking at types of provision to levels of need. And they used mental health as one example. And this work, this 5 levels of mental health, was developed alongside mental health professionals and clinicians to provide a set of guidance levels to nature-based providers and to the link workers so that they talk the same language. And so looking at the levels, you'll see that the need for the individual increases from left to right, and so will the requirements for delivery in order to meet those needs. And so level 0 really isn't an intervention, if you like. It's something we do in our everyday life. And level 4 was clinical settings, and leaving three levels, which is where most of the organisations delivering something green, if you like, in the UK operate. Michelle, do shout or wave at me if I'm going over time, won't you?
You're okay.
So
You're okay.
I'll whizzle through. So yes, so the mental health outline levels outlined in the graphic enable providers to identify the level of need they can cater for and refer us to make sure that the setting that they're referring into is appropriate for the needs of their patient. This was sort of a big concern that we want to make sure that clients are or patients are matched to the right provision. So that was where the 5 levels came in. And then in 2024, another group, the Therapeutic Horticulture Stakeholder Group, decided to map gardening, different levels of gardening provision onto these 5 levels of mental health. And this was done really to produce something that we can use to communicate our offer to mental health professionals. Now, this is just the pretty picture from a paper that covers things in a lot more detail, why it should be used, how the individual will engage with gardening individuals, skills, quality assurance and evaluation processes, and that sort of things, those sort of things. So I urge you to read the whole thing if you're interested, but I'm going to skip on because I want to focus on the work that I've done. So that visual was really, really useful, but it became quickly apparent that it had wider implications for the bigger sector. So not just applicable for gardening. A lot of it crosses over with other types of intervention. And also, of course, this was mental health. There's also parallels for other scenarios, different health conditions, social care, specialist education, whatever, rather than just mental health. But we took this graphic further and we matched it to our 3 pillars, essentially. And the observant of you will find that our 3 pillars has merged into sort of 4 circles, but in order to to fit into the 5 levels, but it's still nature and everyday life, nature-based health promotion, and nature-based therapies, and how they match to the different levels. So again, this is really to aid communication. And as before, it enables providers to identify the level of need their organisation can cater for, and also, and crucially, to enable them to say, no, we operate in this circle and we can't cater for people outside it. So I think that's also been useful for practitioners to be able to frame their offer and to say what they can do and what they can't do. And of course, it enables social prescribers and other referrers to assess the suitability of the offer. So, I mean, generally, if you can deliver for level three need, you will also be able to cover 0 to 3, but not the other way around unless you upskill. So, and I think the other thing that this diagram has been really useful for is that we've got many organisations who operate across different pillars. So they might be delivering a nature-based therapy program at their site. They might, on another day or in another area, provide sort of community gardening groups and other sort of nature-based health promotion activities. And they may also have public access areas that people can, can wander around in their own time as part of their everyday lifestyle. So this tool really enables them to communicate that, and it's been really useful as a comms tool. But as I said originally, mental health is just one example, and we'd love to look at other conditions in the future. So I think I'm going to stop there, and I appreciate this has been a whistle-stop tour of our terminology journey in the UK. I hope you've understood what my sort of gabbling through it. If you're interested in any of the papers or any of the sources, I've got a full reference list here that we can share. I presume we can share the presentations after this anyway, and of course the video will be available, so you can always pause it and have a look. And so, yes, all I'm going to say now is thank you very much for listening, and back over to Michelle and then Jess, I reckon. Thank you.
Oh, but thank you, Rachel. Again, the amount of work and intelligence and growth that those models have taken over the past few years, really, the way in which you described that was brilliant. And I think the chronology of that development, and as things have developed, as the evidence base has grown, as we started to learn more about the needs of different populations and how different levels of nature apply to those, this is always constantly being evolved and developed. And so I think what you did was articulate that journey really, really well. Thank you. And it reminded me to kind of say, because we've got over 60 odd people in the room today, a real mixture from the States and from the UK as well, that in the UK, Green Social Prescribing, there's the funding route, because obviously we have a national health service. I nearly said a natural health service there. We have a national health service, which is funded through our government. Unfortunately, whilst some of the referral pathways are funded through our primary care networks, etc., the delivery of the nature-based interventions are not. So there's a real challenge with the funding and the way in which we can look at the pathways of referral. The funding doesn't always follow the individual, despite their level of need as well. So it's just keeping that in mind when we now listen to Dr. Jess Thompson, who's going to talk about the rather tricky world of pathways and understanding these systems, because whilst we've got a really nice now parameters around the different types of nature that are offered for well-being, getting people to those and supporting them in there presents some different challenges and complexities. So Jess, over to you.
Hi, thanks very much, Michelle, and thanks, Rachel. Really lovely to be on this call with you all today. I'll just share my slides, so bear with me. Hopefully this will work smoothly. Doop-a-doop-doo. Okay. Does that come through?
Yes, yeah.
Brilliant. Well, thanks again. I'm Jess Thompson. My day job is Chief Exec of City of Trees, which is a community forest organisation based in Greater Manchester. So you can imagine the industrial north. And I suppose we're a bit like, so these are the organisations that I think that we're like over in the States, if it helps at all. I think we're a bit like Million Trees, New York City, Friends of the Urban Forest in San Francisco, LA Tree People, that kind of thing. So I've been working in this sort of area for the last 20 years, and I haven't always been chief exec. I came through as a project officer, and over time, I took on lots of roles which were around engaging our communities in helping to develop and look after our trees and woodlands and green spaces, but very much in a kind of urban setting. And over that time, I developed an interest because of the work that I did and the feedback that we get, either through evaluations or anecdotally. It was just really powerful. This sort of sense of when people get involved in their nature in their at a neighborhood level where they live. And so that prompted me to sort of, I guess, enter the world of research. And Michelle was my supervisor, completing my PhD after many years last year. So that's kind of my background and my interest in all of this. And I suppose when as a researcher in this, I was reading sort of all this new literature that was coming through and the work of Rachel on the call here today. And I was thinking, yes, yes. So when I saw those three different ways in which people interact with nature, as a practitioner, I thought it was brilliant because it can feel very messy because it encompasses so much stuff. And at last, I felt like we had this sort of framework to really start thinking about, from a practitioner perspective, what we do. And so I suppose, and then over time, this movement has grown called Green Social Prescribing, and there is sort of confusion over that being a descriptor, that kind of covers everything around engaging people in nature, through to I'll come on to talking about it as a very specific pathway. So I was really interested in how, I suppose, from an environmental practitioner, how that clicks into all of this thinking, this deep thinking that's been happening by the likes of Rachel and Michelle and others, that has a real health focus and academic focus. So that's where I'm coming from. And I've been tasked with looking at talking about pathways. So I must apologise. This is my one slide, but it's such a busy slide. I'm sorry it's so busy. I'm going to walk us through it now. And when I looked at this, I thought, God, it looks like a circuit board or something, doesn't it? It's awful to look at. But then we talk about actually in the apron groups about how there's a lot of wiring that goes on in terms of helping to look at things from a system perspective, everything from funding to reaching that person out there on the street with various levels of needs and the outcomes. So, yeah, we do have to look at the wiring sometimes, don't we? So that's where we're at with this. Right, I'll move on. So, this is all about pathways, but actually, and what I mean by pathways, what we mean by that is how people actually hear about something happening, an activity happening, and then decide that they want to go and join in and give it a go. And the rest is sort of their journey and history, really. But I find it really difficult to think and talk about pathways without looking at the bigger picture. And so what we're seeing here is a slide that attempts to show an overall system for nature-based activities, how they're funded and who delivers them and how people get involved, the pathways and the outcomes that they support. So if we start at the top then, in terms of funding. Oh, and the other caveat is I am an environmental practitioner. So this is what I had in my head. And a lot of it has been really simplified, but I'm really conscious that there's a ton of other stuff that a health practitioner will be able to add to this. So this is work in progress. So it's just to say that before I continue. So let's start at the top of this sort of system and model when we think about funding. So on the left-hand side in that box, I've put that there's funding out there for things like nature recovery, for climate resilience. So that's for climate mitigation and adaptation. Tree planting is an obvious one, but it extends to other forms as well. But very much, they are usually most environmental organisations, certainly the key ones that are here in the UK, aren't just about the environment at all. They're about people and they're about social outcomes. And those two things are really important because at the very heart of many charities' work and other organisations, you can't do successful nature recovery in an urban setting without involving people. And so this is a really a kind of a common scenario over here that environmental organisations have a real kind of focus on social outputs as well. And the funding for that comes from a whole mixture of stuff. And at the moment, we're really benefiting from government funding, which came through in 2020, and that was for Nature for Climate, and that's been a real game changer for a lot of environmental organisations. So even in Greater Manchester, we're talking tens of millions of pounds coming through to transform landscapes through tree planting, etc. So there is funding out there. Similarly, there's more funding coming through from the private sector for this type of stuff, and also grants and trust foundations, that kind of thing. So this type of funding from an environmental project organisation perspective, it's very much business as usual. Not that makes it sound really lax, and it's not. It's still really difficult to secure this funding, but there's perhaps more funding out there to fund this type of thing, these types of projects, than there is flowing from the health sector. So if you move over onto the right-hand box, and as Michelle has already said, we have the I said natural health service as well. We have the National Health Service, and obviously we have public health as well, public health departments. But the funding coming from that tends to be for to fund some of the infrastructure. So there's been some investment in things like community link workers to try and be those sort of links that help to look at people's needs in a holistic way and signpost them to various things that they could do, services that are available. And the funding for that tends to be for what we're all calling Green Social Prescribing projects. So there are commissions where they will fund some activities, but it's not for very much money, and it tends to be for very short periods of time. And naturally, because it's coming from the health sector, it has very tight criteria about how that funding should be spent. The big question, does it work? If I invest in this, money is tight, does it work? Is it going to make people feel better? And as such, that has a big impact on the way that that particular type of engagement might run. So you might have a sort of course of treatment model where you've got to get so many people engaged over a certain amount of time in order to be paid, etc., etc. I'm getting into detail, but the devil is in the detail. So we have two funding streams. I see it at the moment. We've got the kind of business as usual. There's more funding flowing, and then there's some funding coming from the health sector. And then we have the organisations. So there are a range of organisations involved in this picture. There are naturally, I've already talked about those environmental organisations or bodies whose purpose it is to deliver environmental outputs, so many hectares of green space in better quality, or so many trees planted, whatever, but have to have those social outcomes as well. And then there's another kind of sector, and I've generalized massively here, so I've oversimplified this, but moving across the sort of what I've just labeled other service provider organisations. So they their core work may well be to support a specific population or provide a specific service for a particular need. And so I've given two examples here. Mind, which is a big national mental health charity here in the UK. And then I've also given a micro organisation, small organisation, massive impact, Garden Needs. So they're a locally to me based organisation that have a set place and space, which is essentially a big growing space where they engage people in that nature therapy activities that Rachel was talking about. So there's still environmental, but it's for a purpose, very specific. And then over on the right, we have, of course, the health sector. And so that would include everything from GPs to specialist provision, but also within that other trusted community provision. And Rachel actually shared with me, when I first shared this model with Rachel and Michelle, Rachel has said there's a lot of work and there's a lot of complexity that goes into these oversimplified boxes. So Rachel's done work, to date, just looking at that right-hand square there in purple. So again, just as a caveat, these have been overly simplified, but a lot of this complex, very complex picture. And then I thought it was useful actually to highlight that very often, in my experience, there are partnerships that form between an environmental organisation and a care service provider. And so what you're doing there is you're bringing together expertise and different strengths, which are really complementary, because you are able then to enhance your offer. You're able to sort of neatly click into another organisation because you have shared sort of aims and objectives. You can also share resources in doing that. And I think for me, and I don't have any evidence for this, it's just anecdotal, it's off my head, this is where the activities have been way more sustainable because we've been able to work in partnership, draw down a variety of funding to try and continue activities through a really good partnership, so environmental and sort of care and health. And then we move on to pathways. So this is actually, how do people reach activities? How do they find out about what's going on? And the one, this sort of the larger box there in black is kind of, this is the day-to-day stuff that's been going on for donkey's years, actually, where you would have organisations, whether an environmental body or a health or service provider. We all have our outreach programs that aim to target specific audiences, don't we? So it might be a particular postcode or area of deprivation. It could be under, we want to target those who feel isolated, so you might run a campaign on that. It could be around EDI, or just to sort of address a specific need. So I've put an example here for those for people living with dementia or mental ill health. So there's always outreach programs where you're trying to reach into the community and hope that people will connect with what you're doing. In order for you to achieve your core aims as a charity or as an organisation. And then there are initiatives, aren't there, that come and go. So, we have social media, we've got forest bathing has already been mentioned. I think 10 years ago, barely anyone had probably heard of forest bathing, and now it's the thing to do, isn't it? And show off and so on. So there are trends. And there are initiatives that come and stay and come and go. So just as another example here, we have a lot of the private sector, as part of their workforce wellbeing, will offer people a day to go and try and volunteer somewhere for a day or 2 days. And very often that's how you can get people hooked. So there's lots of initiatives like that are out there. And then there's just general comms and promotional activities. And of course, we've got social media now. So all of that stuff goes on, doesn't it? You may have seen flyers, you'll see campaigns, etc., etc. If you're interested, you'll hook into it on social media, that kind of thing. So that's the sort of day-to-day stuff. And then over on the right in green, We've got this newer pathway, which is social prescriptions. And in this context, it's green social prescribing. So this is a pathway whereby you've been specifically advised by a trusted person, your GP or somebody else, a link worker perhaps, to say, listen, why don't you have a think about having a go at this? If this is what you enjoy doing and this is what your needs are, this is what I could recommend that's available to you on a sort of community level. And that is it's a much newer pathway. It is a pathway though, and which is kind of, because of the interest in this, is kind of swallowed and sort of I suppose in some respects it's become the thing to describe this whole system that we're talking about here now. But it is a pathway and there's an awful lot of work going on to try and improve that pathway because it's such a good one. But I suppose my overall sentiment in this is the reason why our language around this is so important is the vast majority of people, I would say, coming through to undertake nature-based activities aren't coming through the green social prescribing pathway at the moment. They're coming through other means, but it doesn't matter, does it? Because at the end of the day, as long as people are finding the activities and that's working well for them, that's the important thing. And then, so we move on then to the activities. These are the three pillars that Rachel has just described here. So, from an environmental kind of organization perspective, it is about encouraging that everyday contact with nature. Go and, use your local park, walk your dog, take a run, all of that stuff. And then we've got moving across, we've got nature-based health promotion, of course. And I think this is where I think a big chunk of environmental kind of engagement probably falls under this one in terms of health promotion activities. So these are activities where people will just rock up, turn up and have a go and join in. And often they get hooked and they carry on doing it for lots of reasons. It could be around, because they met a load of people, it makes them feel good. Lots and lots of different reasons. But in many instances, it wouldn't actually ever be advertised as a health activity. It would just be come and join in this particular thing and so on and so forth. And that's worked well for a long time, actually. And then, of course, we've got over on the right, nature-based therapy activities. And these are probably what people perhaps have in mind a little bit more when we think about green social prescribing, because it feels a bit more like a course of treatment to target a defined need. But the health promotion activities are really important from a green social prescribing perspective because there's perhaps more of those around for people to join in. And it's really important that people are able to have a go. And Rachel's work has, if you look into that further, I'm not sure if we talked about it today, but people may float or pass through each of these different kind of ways of connecting with nature. So in between everyday contact with nature, going out for a walk, to health promotion or nature therapy. And that's good, that's right. And what we want is a really rich picture, don't we, that covers an awful lot of this stuff off. So there's so many options for people to get involved. And of course, the outcomes are just what they say they are. I guess the everyday contact is about sort of healthier lifestyles and just maintaining that crucial access to nature that we need, the exposure. And then the health promotion, again, just much more about you've probably self-directed, found yourself there. Nobody's perhaps told you that you should go. If they have, then that's great, or suggested it to you. And that's about supporting self-care and living well. And of course, the nature-based therapy activities would be, I guess, people's journey to recovery. So I've blathered on, and I hope that has made some sort of sense and I haven't put everybody off by that quite horrible graphic. I need to work on that, that's for sure. But yes, that's it.
Jessica, you haven't blathered on at all. That was brilliant. I think again, the journey that we've taken as academics and practitioners in the UK to get to the point where this chronology and this development can be put onto a slide to try and describe the pathways has taken some discussion and again evolved over time. And it is messy because it is, and I think the different pathways that enable somebody to access nature for the benefit of their well-being is complex. And I think Jessica and Rachel both highlighted the fact that in the UK, Green Social Prescribing has kind of taken off as a concept, and globally it seems there's a lot of interest in this. But as you can see from this, from the diagram, but also from Rachel's discussion earlier, it's not the only way in which people can access nature and gain a benefit. I guess because it aligns with and was kind of part of our national health service, which is quite unique to the UK, it did provide that kind of visible pathway for clinicians to enable people to get to nature for a variety of different non-clinical reasons. And this is why we thought it was really important for the team from the national evaluation to come and talk today about what they found. So this was kind of a study that was funded, and Harry will be able to give more details, last year and the year before, to try and unpack some of this, to try and understand what the impact of nature-based interventions are, what role Green Social Prescribing played in that, where referrals came from, what type of people access this, what's the health impact. Again, a complex study, but a really informative report that really helped to shape and further our understanding about, well, how do people get there? What is the impact? What are the systems in place? So I think Rachel's presentation and Jessica's leads us really nicely into the evidence. You know, what have we learned from our national programme? So Harriet, I'm hoping that that's enough of an introduction for you to kind of take it away with the national evaluation. And then, of course, please, just start thinking about questions that you might ask. I've written down loads about what's happening in the States, but so yeah, over to you, Harriet. And thanks again, Rachel and Jessica, for really setting the scene brilliantly.
Thanks, Michelle, and thanks, Rachel and Jessica. You've teed it up perfectly. So let me share my screen. Let's have a look at that. Is that working for everyone?
Perfect. Yeah.
Brilliant. Okay, so thank you so much for inviting me to share some of the lessons from the National Evaluation of the Preventing and Tackling Mental Ill Health through Green Social Prescribing project. I won't be using the full title throughout the presentation. So I'm presenting as part of the National Evaluation Consortium, which was a large group of researchers from the University of Exeter, Plymouth, Sheffield and Sheffield Hallam. So whilst I'm presenting, there's a large number of real experts behind what I'm putting up here. And so what I'm going to be talking about today is not about whether Green Social Prescribing works, but I'm going to be talking about what happens when you try to embed it inside a national health and social care system in England. And the QR code in the bottom right-hand corner there is a direct link to the DEFRA project site that hosts all the publications from the programme so far, including the final report and a summary and policy briefing and other bits and bobs. So you can follow that. I've also put in the chat a direct link to those papers and also to my colleague Becca Lovell's Beyond Green Space blog, which might be a bit more accessible and also hosts all the graphics that we had produced for this project, which were done by our collaborators Scriberia, and they've really brought a lot of this to life. So firstly, why does context matter? Well, as we've already heard brilliantly from Rachel and Jessica, there's a big and growing evidence base, and we've got a lot of our international colleagues here who have contributed really strongly to that and continue to do so through a lot of the Horizon projects, for example. So we're past the does it work stage. But there are a lot of pilots and projects that vary in terms of scale, relevance, quality. Sometimes it's unclear where the evidence relates to in terms of whether it's the pathways or whether it's the interventions. And implementation is often fragmented or boutique in terms of it's very, very specific to a small scale, according to a lot of these restrictions or designs that are necessarily small scale. So one of the big questions is, how do we move from good projects to routine pathways? For the National Test and Learn programme, our evaluation focused on system level interactions rather than specific green social prescribing interventions themselves. So we were exploring referral routes, who connects people to who, and how these relationships operate. So this graphic just shows an example of where people might find out about green social prescribing. Again, a lot of you will be very familiar with this in the reality. But for example, we've got education and community groups, families and friends, job centres, housing officers, mental health workers, referrals from social prescribing link workers via health practitioners or other outlets that support social prescribing link workers. Within wider social prescribing, organisations like the National Academy for Social Prescribing, NASP, talk about no wrong door policies. And that really supports what our approach was here. And it sits alongside that 3 pillars framing that Jess was talking about a minute ago. So at a glance, the Green Social Prescribing programme that I'm talking about here was a cross-government programme in the UK and specifically in England, ran from 2020 to 2023. It was a 2-year programme, but it spanned October to April. There were 7 test and learn sites selected across England. We're very fortunate to have some of those project managers here on this call. And they were from around the country. So Humber, Coast and Vale, Nottingham and Nottinghamshire, Derbyshire, Surrey, Bristol, North Somerset and Gloucestershire, Greater Manchester and South Yorkshire and Bassetlaw. And they cover a really broad range of urban, rural, coastal, inland, and really broad range of settings and locations. There was a mental health focus to the programme, so that was sort of one of the primary sets of outcomes that were measured. And our evaluation looked at systems and outcomes evaluation. So our primary aims were to understand different systems, actors and processes in each site and then across sites, and how they influenced, improved potential mental health associated with green social prescribing. So another of our aims was to understand those system enablers and barriers to improving access to green social prescribing. And that was particularly looking at underserved communities. Our third aim was to understand how green social prescribing was targeted at particular groups. And again, bringing in those sort of diverse communities. And our fourth aim was to improve how we understand how to successfully embed green social prescribing within delivery and within the wider sort of social prescribing landscape. A lot of our research was realist informed, particularly our qualitative work, and we created programme theories, which I'm not going to talk about in this presentation, but actually if you are interested in that more practical, realist based research, it's really worth going and looking at our fuller reports. And when I say realist informed, what I mean is rather than a straightforward effectiveness evaluation of whether something works or doesn't, we were looking at how things work in context, for who, in what circumstances. So really digging into the intricacies there. So did it work? Well, we have an awful lot of ways of measuring whether the green social prescribing programme works in different areas for different people. We had data collected from 8,339 people with mental health needs, and they were supported to access nature-based activities. The programme reached many, many more than that. 57% of participants were from the most socio-economically deprived areas in England. 21% of participants were from ethnic minority populations. And we found statistically significant improvements in wellbeing as rated by ONS4. And this is shown in the graphic here, after people had taken part in nature-based activities. So happiness increased from an average of 5.3 to 7.5, life satisfaction increased from an average of 4.7 to 6.8. Feeling that life is worthwhile increased from an average of 5.1 to 6.8, and levels of anxiety reduced from an average of 4.8 to 3.4. There were quite a few other measures that individual sites took and assessed. And for this evaluation, we didn't carry out a full cost-benefit analysis because it was very complex in terms of the picture and the range of green social prescribing projects taking place across the 7 test and learn sites. And so that meant that the data were very partial and limited in terms of carrying out a cost-benefit analysis. But we did look at social return on investment, and again, those details are within the report. The qualitative evidence, so looking at people's experiences, was woven throughout all our findings, and it gave us the bedrock of human experience that then we built on with the hard metrics. So we've got some of the quotes there on the graphic. It helped me relax and feel tranquil. I feel joyful, happy, calm, have a sense of achievement. We're doing a lot of nature stuff outdoors. We're all getting along and opening up, making friendships out of it. So again, if you're interested in the qualitative data, do go to the main report, because there's an awful lot in there and it's rich, rich data. And also, obviously, it reflects a lot of people giving us their time and their experiences. And that was one of the outstanding aspects of this programme of work. So what did make green social prescribing work within the programme? The key 3 things were relationships, capacity, and practicalities. That the graphic I've shown here says green social prescribing success requires collaboration between all statutory and VCSE or VCS. No, sorry, VCFSE sector partners. So those key tenets of understanding, trust, respect, collaboration were really central. Trust between NHS and community organisations was really key. So having freedom of movement, for example, to manage budgets, to work across different funding cycles, and to plan according to different local needs was really, really key. Importantly, key individuals, so for example, project managers of the test and learn sites, were vital to success in this area. And as one person put it, they held the agenda, and that was really, really important in our observations. Having potential participants or service users meaningfully involved within local green social prescribing systems was really valuable. So, for example, one site had service users on local funding panels, and they decided who got funded to be a green social prescriber, green social prescribing provider. And then also having genuine representation for target communities within all the planning stages, as well as sort of delivery and monitoring and evaluation, was really valuable. Looking at capacity, having providers that were ready and trained and funded was really, really helpful, as well as providing them with some stability so that they could continue and plan ahead. And the citing of different bodies mattered. So, for example, where organisations were supported by integrated care bodies, that really, really helped. And there was, shared oversight, shared governance, funding that could be a bit more flexible, particularly if there were gaps coming up. Again, personnel could be shared across different projects, and there was sort of far easier access to wider infrastructure, buy-in and adoption. And then those practical elements that we found helped, like transport, helping people to get to green social prescribing activities. If providers had budgets to support that, it was really, really useful. Having clear referral mechanisms, again, from what we've heard already, sometimes it's not straightforward how people reach these activities. Link worker training and support for sort of capacity building was really important. And then referrer awareness of what was out there and what was on offer was really valuable. So the challenges, there were a few challenges we came across. Again, I won't go into these in detail because there's an awful lot, and it's very nuanced as well. So it's a real complex system. There are bound to be lots of different areas that are more difficult for some than others. Funding, you won't be surprised to hear about, came up an awful lot was a major issue, particularly where it was short term, it was restrictive. For smaller organisations, it left little support for infrastructure or core costs. So there were some sites we came across, some providers who were personally funding their own computer equipment and their licenses because it couldn't be paid for by funding for GSP activities. The 2-year timeframe for our evaluation also limited what we could look at. So building relationships and trust and having shared visions takes time. And then balancing this with delivery and outcome measurement was really challenging. And there were sort of clear barriers where the system isn't one size fits all. So success depended on person-centered conversations, that whole what matters to you core of the conversation. So it needs to be tailored, it needs to be responsive to the people on the ground. And then finally, evaluating such a large, complex, multi-partner system meant we had moving goals, there were differences in power dynamics, there were competing perspectives, and it all meant that capturing impact was really difficult, but really valuable because it's not often done in the way we were able to do it at this scale. So where does Green Social Prescribing fit? The fundamental aspect of our learning from the national evaluation is that it's around system changes, not a treatment or a programme or a single intervention. Those enabling pathways which connect individual health to community assets helps to reduce friction between sectors. So that's really, really important. Funding needs to be creative and sustainable. So there needs to be that whole system support from commissioning onwards. Infrastructure formalises that nature accessibility at scale, at country scale if needed. And it needs to be equitable, so you reach neighbourhoods and communities where they are. I heard it put that Green Social Prescribing is connective tissue between key ingredients. So between those activities, participants, providers, referrers, funders. So how do we fund it sustainably? How do we embed it in our structures? How do we train link workers going, into the future? How do we build provider capacity? Well, the key messages are that if Green Social Prescribing is infrastructure, not an intervention, then the priorities shift. So for researchers, we need to study how things embed and scale, not just whether they work. How does this become routine, for whom and under what circumstances were, some of the key questions we were asking. And this looks like implementation science, realist evaluation, analysis of workforce and referral processes, or exploring equity and access. All those sort of important, but maybe slightly less visible ways of evaluating effectiveness and sort of suitability for different populations. For practice and practitioners, we need to look at how relationship and infrastructure really matter as much as programme design. So they need to be treated as real core aspects, not add-ons. And for policy and commissioners, we need to find ways to commission the enabling infrastructure, so link workers, coordinators, community capacity, not just short-term projects. It needs to be a whole system approach. So my closing thought is that if nature is a determinant of health, then access shouldn't depend on chance or charity. Green Social Prescribing is one way of making access systematic, or at least more systematic. And that's me done. Do get in touch. That QR code is for my email address and contact details.
Harriet, thank you. That was perfectly timed. And
hooray!
Wow, amazing. And thank you. That was such a great insight into Green Social Prescribing, the complexity of that national evaluation that, as you said, involved SRIs, qualitative research, impact on mental health. And at the end, I think you highlighted a really significant point in that we know it works. It's about embedding in what the systems that will enable this to happen to help that be an equitable, accessible model for everybody. And I guess that really reminded me of Jessie's presentation and Rachel's as well around, that I want to say ecology of change that we've gone through over the years to enable us to actually get to this point now and go, yeah, we know it works. How do we embed this? And given the fact that in the UK, like England, UK, we've got the National Health Service, but it was reflected differently in different countries. But we've got a mechanism there, one mechanism out of many. We've got a strong voluntary sector. We've got a new 10-year plan launched by our government, which is all about neighbourhood-based services, place-based approaches around promoting well-being for those communities that are most in need. It's shifting the focus from hospitals to communities. It's shifting the entire way in which we look at health and well-being. And I guess in the UK, we're kind of we do have this platform to enable that change to happen, but it's not without its challenges and its complexities. And I think, and I hope that the kind of speakers have highlighted some of the benefits but also some of those challenges that we face despite having what I think is quite a strong advantage with our policy and health system. And so I wonder, and I have got a lot of questions of, well, what happens in the US? What is that reflection? What does that system look like, given the size, the funding structures, and everything else? And so I'm hoping that we'll be able to find out a lot more about what happens, but also whether or not any of what we've talked about today has got you thinking, how could this be implemented? I don't know, a federal level or a state level? What does that look like? I have no idea. But first of all, let's give a huge virtual round of applause for our speakers today. And thank you so much. I kept thinking, I have to remember this is UK, and so some of the terminology that we might have used, please do ask us. I'm very mindful we might know what DEFRA is, or NASP and things like that. So yeah, thank you so much. Right, I wonder whether or not we could open up for questions, whether or not you want to put something in the chat box. We did want to think as well about, based on this presentation today, what colleagues might want to learn more about in a second symposium where we can start to provide some examples. I mean, obviously Harriet's described the test and learn sites and where those took place. Jessica is, leads the City of Trees. We've got members in the room here that lead a variety of different organisations that deliver a variety of different nature-based opportunities for people to support well-being. And so they're all chomping at the bit to go, right, we really want to describe what we want to do, but what are your thoughts and feelings from the room? What is it that you would like to know more about? But importantly, what do you do, over there, over the pond? What is it that you do, and what are the challenges? And is there anything that we've talked about today that reflects your world, and the complexities that you might be operating in? Or is it so very, very different that there's no kind of comparison? So yeah, I'll kind of open up the floor just to see whether or not anybody has any questions. But my opening question to people, our colleagues, is, what happens over there? How do you get people into nature for well-being? What are the systems that are in place? Are there any? It'd be really good to understand what they are, and any descriptions or any kind of challenges to that, or solutions that we might be able to share. I should talk now. So yeah, over to the floor. Has anyone got any questions? Just raise your hand or pop something in the chat box, or any comments. So Owen, you've put something in the chat box around you sit on the National Committee for PAREX in Canada's Nature Prescription Programme. So you're curious about the barriers to uptake by healthcare providers we face in the UK. So you're up to 20,000 prescribers, but always looking to access more. So Owen, I don't know whether you want to add anything to that or not, but whether or not there's anybody in the UK that's kind of willing to make a first response to that. What about how do we get clinicians? So I guess from our perspective here and some of the challenges that we found. So I kind of respond to this because I'm a qualified nurse by background. So some of the challenges that we do face are around convincing clinicians that this is a safe and effective opportunity for wellbeing. And the evidence base, whilst we know nature-based interventions work for people with mental health or ill health, we sometimes know less about whether it works for other populations. Ironically, the idea around green social prescribing is that it's not prescribed to people with a clinical need, rather the opposite. It's prescribed for a non-clinical need, but often the measures that we use are not necessarily clinical outcomes, but health outcomes that clinicians might like to see and understand. And so therein lies a challenge, because on one hand, we try not to over-medicalise the system and a process that works for many people in need. On the other hand, particularly the clinicians and referring people to a nature-based intervention often means that they look for a specific type of evidence, more experimental, randomized controlled trials as part of their decision-making process. And that's underpinned by policy and practice, underpinned by a lot of different challenges. So sometimes there is that challenge to understand, well, yeah, we do have the evidence base. A lot might be subjective, self-reported, but it's strong. And we do have those validated outcome measures that we've used to measure things like mental health, physical activity, etc. But sometimes it doesn't always fit with the nuances of what would be needed for a clinical pathway. So I don't know whether or not, just going back to Owen's question, whether or not it's similar, because clearly you've got a lot of people already signed up to your program, whether or not there's any challenges that you face particularly, or any specific questions that clinicians ask. Maybe not. I'll move on to a different question. Is anybody in the UK want to respond? Anything that I've missed in terms of some of the challenges? When we do have clinician buy-in, it's amazing. And those champions out there are really supportive of both green social prescribing, use of nature for wellbeing. And there are a lot of programs that have come out of PCNs in particular that support access to nature for people with a need. So I would say it is growing, excuse the pun, and interest is growing, and the evidence base is certainly growing as well. I'm just looking at the chat box. So Holly, you put something about one of the areas of mental health where nature connections is vitally important and lacking is within hospital and end-of-life care. So I'd love to see more exploration and problem solving the barriers in this context. I think Jill, you just responded to that. And I think as well, there was, when the last symposium, there was some great presentations using virtual nature where there was people at the end of life, and it had a huge impact on their end of life experience, didn't they? And I think Taylor could probably connect you with that. And I can't remember the name of the individual that specifically talked about that end of life project, which is brilliant.
Absolutely. That's Olivia McNairlin at Clemson and Matt Browning at Clemson. So I'd be happy to send more info on that. They're always happy to talk about the work they're doing. But we do have a raised hand in the chat. Jessica, do you want to chime
Oh,
in?
I can't see that. Thank you.
Hi, yeah, I just wanted to pick up on, is it Jack Spengler? He's put something in the chat around a suggestion for future sessions, hearing about prevention and is health promotion a part of the education and practice of landscape architects and designers? I think that would be great actually. And we had a similar conversation, didn't we, recently? It was either perhaps at the APRIM meeting around there's been a real focus on nature therapy, which is really important for obvious reasons, because that's to target people probably in the most need particularly when it comes to mental health and things. But a focus on health promotion is I just think, yeah, because we're talking all the time, aren't we, about prevention and self-care, because the our health service is I know we have a health service, so it's not a complaint at all. But it's really, really, it's overburdened, shall we say. We're incredibly lucky to have it, but it's really overburdened. And particularly, just take Greater Manchester as an example, far too many people who are of ill health and way too many health inequalities as well. So, if you're born in one area of the conurbation, your life expectancy is more than 10 years less than somewhere else in the conurbation. So just incredible statistics like that. And so I think, yes, let's do something on prevention. And it's interesting that, Jack, you put there around the practice of landscape architects, because for me, that's really veering into that nature in everyday life as well, which would be really interesting to focus on. I don't know if Jack wanted to.
Yeah, no, let me elaborate. Thank you,
Yeah, please
Jessica.
do, Jack. Hi.
I'll keep my video off because I'm in the sun. I look like a ghost here. There's a quick there's a quick shot. All right, so you see why. No, we find ourselves, and Linda Tomaso is part of our group from Harvard, working with landscape architects, designers, to one, bring nature indoors. We've seen the great studies done in hospital settings, but to make it very much part of our offices, our commercial property, our homes, I think makes a big difference. So nature isn't something outside of us, outside of our built environment that we have to go to have contact with. So I think that's an important aspect. But I think we find ourselves at a unique time where we have the complexities of the burden of high health costs, the excessive amount of public mental health issues, and climate change. And so we're looking for nature-based solutions that optimize both what it can do to mitigate storm waters, to cool cities, but also perform to make our urban environments healthier. So that's the nexus that I think it would be worth exploring. So it's not all to the obligation of our healthcare delivery systems to latch on to these benefits, but we integrate it into more societal functions.
Hey, thanks.
Absolutely. Jess, is there anything else you wanted to add? You've got your hand
No,
raised. It's spotted
no,
it in the
yeah.
corner. Brilliant. There's quite a few questions and responses in the chat box. So I know Melissa Marcel, are you the same Melissa Marcel that I met a number of years ago?
Yes, I am. Yes, same
Hello.
one.
Thank you. So you put in around, because it is higher, it is a real kind of methodologically now moving towards this kind of re-evaluation to look at what works for who and why. So I noticed Harriet had responded in the chat box to you as well. But I'm just wondering, because then you mentioned something around theory of change. So I know that's something that we're using quite a lot now to kind of understand, work backwards and go, what are the ultimate outcomes for who and why? And what are the mechanisms that enable that change to take place? And increasingly, having been in academia for like 25 years, in the past, I'd say 12, 24 months, the number of times now we use theory of change and realist evaluations has increased tenfold. And I don't know whether that's a similar experience with you, Melissa, or with other researchers, but it strikes me that it's a really great methodology to get to the meaning also. I mean, Harriet, you talked about the reason why nature-based interventions work is because they're bespoke to the individual, but that also creates challenges in terms of how we then capture that and measure that. And realist evaluations can go some way to enabling us to do that. I don't know where they fit within our kind of evidence ladder, and because we can use a variety of tools within there, and yeah, I genuinely don't know whether or not are we saying that that is the best kind of methodology going forward, but are we also saying that is that the strongest methodology? It might be the most appropriate. Is it the strongest methodology? And I guess we kind of will see that more and more in the literature. Harriet, you're smiling, so it might well be that we do see that more in the literature. Harriet, what are your thoughts?
I'll be very quick. It's a great conversation and it's really timely. It's one that we have an awful lot within our team because we have a very strong realist section to our researchers, and then we also have our more sort of, I guess, prosaic old school effectiveness approaches, which obviously use mixed methods and different types of evidence, like RCTs, for example, which often are randomized controlled trials, everyone, which are often brought up as being more persuasive for clinical communities, for example. Interestingly, within the Green Social Prescribing project, that was an assumption for getting a lot of clinicians on board, that people would need more clinical facing outcomes. They would need more trial-based evidence. That wasn't the case a lot of the time. So a lot of the time, actually, qualitative experience-based evidence was the real persuader, but it was then the commissioners and releasing funds that needed some of the more treasury attached ONS4 type measures. And you made the point, Michelle, about sort of hierarchy of evidence. I think it's too big a topic for here, isn't it? But increasingly, I think we have far, far more recognised rigorous approaches in the more qualitative sphere, in the more realist spheres. So I'm not sure it's necessarily an either or conversation anymore. I think it's what's needed, what is the question you're asking, what's the issue you're addressing. That's obviously very academic, so that's not always a straightforward answer for normal people.
Yeah, I think as well you raised a point. I've just noticed, Chris, you've got your hand raised, but I guess as realist evaluations, you work with the delivery partners. You're working alongside those people that are providing those nature-based services, in whatever guise that might be, which means that the impact is more meaningful, which means that it's more likely to be embedded, which means that you're more likely to get uptake of the social community, going back to Jack's, and you're more likely to join these dots between nature recovery and human recovery as well, because it fits that wider kind of public health sphere. So yeah, absolutely. It's not a one size, it's not either or, it's that kind of combination, but also bringing on and working with our colleagues. And there's a big block in Jessica's diagram around partnerships to enable us to do that effectively. Sorry, Chris, over to you, Chris Nesbitt.
Yeah, good afternoon, everyone. This is a really great topic of conversation. So someone will have to mute me at some point because I really enjoy this tussle. So my background was very much quantitative and laboratory science, and now I work with Michelle and others in much more qualitative mixed methods and to some extent a realist space. So I think there are some assumptions here that the hierarchy of evidence, it's effectiveness evidence. That's all it is. And I use the word all really, really purposefully. It's just effectiveness evidence. And for me, it clearly suits very simple interventions in simple clinical circumstances. But it's a folly to think that hierarchy is somehow has the pinnacle on top of it, because having evidence for the effectiveness of something has no impact. It just doesn't. We've stacked up decades and decades of evidence that doesn't have any impact. So beyond that hierarchy, there needs to be another series of methodologies, realist and so on, which are actually about the hierarchy of evidence for impact, not just evidence for effectiveness. And we played a few times with what would come above on the pyramid, beyond the systematic review and the RCT, the systematic review, what would come beyond. And of course, that's not true either, because it's not really a hierarchy, because you want to look at implementation and impact from much lower down on the triangle. But yeah, the idea, there's a real risk in us just presenting more and more evidence for what we know already work, which is go outside, be more physically active, engage, be social, etc., etc. The really important research questions are not those. They are, how do you make that happen in people's neighborhoods, localities, and lives? And those do not require RCTs. They require realist and other methodologies. And now I'm going to lower my hand.
Thank you, Chris. Thank you. I guess there's a real kind of theme here around, how do we enable and sustain services that we know work for people across a range of populations through methodologies that are impactful, meaningful. And when I say meaningful to communities, but also meaningful to commissioners and other key stakeholders as well. And I've just been reading through and really mindful of time, because in my world, I'm 3 minutes behind everybody else as well, so we've got even less time. But I'm just reading through the chat box, and I think some of the questions I'm thinking about the second symposia were around, how do we embed nature into systems? What is it? What could we come up with some case studies and examples? Maybe there's some examples specifically around, how we promote health. Those kind of health promotion. So looking at the pillars of engagement that Rachel described earlier from the Green project, do we have some examples? Maybe we could provide some examples and case studies that meet those 3 areas that we could share next week. And I know one person in particular has put in something around secondary care. So I know she's had to leave, but she's a radiographer working with people with cancer in hospitals, and she's been thinking about how you bring nature in to support those individuals that have a real anxiety around their treatment. Quite clearly, how do we look at this from across different sectors as well? So there might be some examples, but before we close, I just wonder if anyone wanted to put in the chat box, is there anything else because obviously we've got a unique opportunity to develop a symposium next time where we can do lots of different examples of the way in which we've worked within the UK to address some of these things, but also to embed, to work with organisations, how we work in partnerships. And I have to say, none of them are perfect, and they're always evolving and we're always learning. But I just wonder whether or not there is any specific areas that you might want us to focus on, or specific examples that we could bring. I can think of lots of different examples off the top of my head that our APRI members could talk about. But if there is anything specific that relates to what you're doing in the US as well. Mike, you've got your hand raised.
Yeah, hi. Thank you so much. This is just so inspiring, and I think understanding kind of the various clinical aspects related to mental health, but also clinical interventions such as cancer survivorship are important. My world has evolved a lot kind of with the electronic health record being the center of work, but we're understanding that in order to improve chronic disease prevention or mitigation, that there's greater need to expand our boundaries to community-based organizations. And there's a gentleman actually out of the UK, is Jens Malbec, with a group called New Impact that's focusing on cooperative concepts that are tri-segment collaborated, public, private, and social. One of the things I think would be helpful is to start to define and understand the technical barriers such as referral requests and things that may be required for, say, order standards that exist within our current systems of operation in health systems, because we know that that's already a barrier in our country. And really working to translate that to the payers, the insurers, I think is kind of one of the areas that I think it's going to take a while to get us to. So I just want to provide some of that context and some of the areas that we're focused on as it relates to the handoffs between nonprofits, community-based organizations that may provide those services.
Yeah, that Mike, excellent question. There are kind of platforms that are used not as a standard in the UK, but I kind of won't name because they're all business in their own rights that are aligned to our GP. So for green social prescribing in particular, those systems are aligned to the referrers. So our trusted referrers, GPs, nurse practitioners, etc., within primary care networks, they can use that system to refer directly in. And there's a range of different systems and platforms that are being used. So we could probably look at some examples to share. And I think, yeah, those pathways, I'm probably not the best person to respond to this, but maybe we could put that question back to the apron to say, what do people use? Because that analog to digital is a real push within that 10-year plan within the health. I have to be mindful that I come from this from a very nursey perspective, and it's not all about health and the health system. But I think, the ways in which we get people from A to B digitally is a really great question to ask. And maybe we could put that to April to see if there's any great examples that we can share at the next symposium as well. So I hope did that make sense, Mike? Have I responded to you?
It did.
Okay.
I can't help but reflect this past Tuesday in the state of California, we held an inaugural session at the California Natural Resources Agency called the Outdoor for All's Initiative, or for Outdoor Access for All. And so when I think about the barriers around technical interventions, technical transmission of communication for these pathways, the session on Tuesday really was comprised of conservation groups, public government groups, nonprofits, social and restoration groups, and each one had their own flavor of possible nature delivery. So it may be worth even structuring an organized inventory list of what those organizations are providing. That would be the starting point that would allow us to kind of map those pathways forward, regardless of country. But I just feel like that's one of the things that would help us at least better formulate the policy needed to move this forward. I can't say enough about the great work that you're all doing and sharing with us today. Thanks so much.
You're very welcome. You're absolutely very welcome. I think, I'm just mindful of time now. I've got loads of things that I'll probably take back to the open group and discuss with Taylor as well. And maybe the next steps now are to kind of formulate that into these are the topic areas. We can then put that out to open to say that's anybody who wants to talk. I'm sure they will, because we've got a lot of members that are very excited about the work that they're doing, really keen to share. And then we put another symposium together, and that would be a really nice way to share. And maybe if we can share the topic areas in advance, it might be that we can get colleagues to kind of think about what questions might they want to ask those particular case studies as well. So I think Candice has just said she's got to go, but I was just going to come to you, Candice, because you did say earlier on you were happy to speak about your experiences of engaging clinicians, but I might have misinterpreted that. So
I don't know if there's time or not. I'm happy to talk about it for a couple minutes if you're interested.
I think we've got a couple of minutes at the end, and I think if we can then maybe look at that again in the next symposium. But sorry, I completely missed it. So final words to you, Candice, and then we shall close shop.
Oh gosh. Okay, well, that's very high pressure. So I'm based in Los Angeles. I'm originally a pediatrician and a Prev Med Doc by training, but have sort of shifted to more community partnered public health programming and research. And I worked with LA County. We tried to start a park prescription program in LA County back in 2017. And I mean, LA is a beast of its own in the sense it's 4,000 square miles and there's 10 million people and there's all sorts of topography. And then you add in the health system and the way that it's structured, and it gets increasingly complex. So we've tried some small pilots. I think both in adult settings, and then we wanted to try it in a pediatric setting, but I think for us, at least in our small experience, that a lot of the barriers have to do with in primary care in the United States, the way that healthcare is reimbursed, in the sense of one, providers already being stretched very thin for time within their sort of primary care or well child visit. And then two, feeling like if they spend time exploring nature, green space, and conversing about opportunities for health there, that's not something that's sort of reimbursable for them. And that's how we're measured as physicians, is in terms of how many units of revenue we sort of generate for a healthcare system in any given sort of visit. And that's more complex for safety net populations because the reimbursement isn't the same for all payers. But we did some focus group and survey work, and it's sort of interesting that providers have a mixed sense. And I think pediatricians are probably some of the easiest to convince about nature's role in health, because they're coming from an upstream and sort of a preventive mindset. But even for pediatricians, many aren't sort of sure whether or not they feel this conversation and this integration into healthcare is actually a role that physicians should play. So it's sort of a mixed bag. And a lot of the other conversations that came in were concerns about equity, because we work in LA, especially in areas where kids maybe just don't even have access to primary care, or we have really a lot of green space inequity. They feel like talking about nature is in some ways dismissive or disrespectful for individuals they feel like don't actually have ready access to nature. So it's just sort of interesting. I think there's opportunity in the sense that environmental health is top of mind for a lot of pediatricians and providers in general, but we tend to come at it from a deficit-based perspective, right? Like, I think the conversation in healthcare right now is about extreme climate events and how that impacts health, instead of looking at how nature can actually be beneficial. We're sort of more focused on the harm mitigation part of things. So anyway,
Yeah.
I'll stop there because I don't want to eat up everyone's day.
That's brilliant. Thank you for sharing that, Candice. And I think we do have some great examples of children, young people's use of nature, and that's a real growing area as well. So, and I know we've put a comment in the chat box as well, but in particular, the way in which children, young people's mental health is in its boots. The World Health Organization has said something that 1 in 5 has got poor mental health. How are we kind of using nature to enable growth and resilience and recovery and improve well-being for all age groups? And we know the evidence base is really strong for adults. So how do we improve that for the younger population? You're right, there's a real strong lens there around prevention and probably more opportunities to do something with that, but equally there are a lot of challenges as well. So just to sum up, I've got 1, 2, 3, 4, 5, 6, about 7 different topics there around CPT, referrals, digital advances, embedding and implementation, health promotion, access, nature, and human recovery. So we're going to take that away. We're going to work on that. We're going to then send it round to April and probably through to Taylor as well. Let's see if we can get a really nice symposium to find some examples of where this is working. So real feel good stuff to go, this is working really well. And so we can learn from that. And it won't all be perfect, will it? But might be a really nice starting position to kind of share what we do, but also the great examples of where we're making a difference to people that really need it, because that's what we're all here to do, through nature. So without further ado, I don't have anything else to add, but thank you to everybody that came today and gave up the time across the different time spans, which I can't get my head around with the States. The UK, it's fairly simple, one time zone. With you guys, thank you so much. Some of you are different time zones, so it's brilliant that you've all managed to get here. And we hope that you've got real value from this. And the recording will be available because Taylor will have it. Taylor, do you have any words to add?
No, I think that's great. Thank you to all the speakers today. If anybody's from our Nature and Health Network and you have some thoughts on the next symposium or some questions or want to follow up with anybody today, feel free to email me and I'll put you through however we figure out makes the most sense. And then I will be sharing the recording with everybody else in the Nature and Health Alliance. So if any of your colleagues said, oh, I missed it, I'll be sending it out.
Brilliant, thank you. So apologies for those who had a question right at the end and we didn't get a chance. But thank you. We can pick up with some more questions later on. And thank you so much to our speakers and to everybody. Have a lovely day, stroke evening.
Thanks, everyone.
Bye-bye. Thank you. Bye-bye.
Bye-bye.
Bye.